This is the Puscast, covering the last 2 weeks of February 2017. 217 was a long time ago. Not much literature to review then. As always, references are available online, and you can go to edgydoc.com to find references and links to my growing multimedia empire. But let's move on to the literature, shall we? A lot of quickies this time, but probably not a lot of deep substance, but we'll see. Once I start rambling, who knows what I'm going to say. 2 quick Zika issues. One is Zika can cause an acute myocarditis, fortunately transient, and Zika can also cause hearing loss. Again, transient. Zika seems to have a lot of badness associated with it over and above microcephaly. The tradition is that zoster reactivates after stress, but is that true? This study looked at the incidence of zoster in people after they lost their partner. They didn't mislay their partner. The partner actually died, and they looked to see if there was an increased risk for zoster, and there wasn't. And this confirms a similar study that showed no increased risk of zoster in someone after they lost a partner. Of course, the obvious problem with this study is the assumption that patients were sad after losing a partner. For all you know, they were happy to see the bastard finally go. And of course, not everybody would see that as necessarily stressful. The concept of stress is really so ill-defined. I remember in med school toting up the amount of stress I had, and based on the points, I should have been dead. There is stress and there is stress. But still, the data would suggest that at least when it comes to death of a partner, it doesn't increase your risk for zoster. And if you didn't know, it would appear the vaccine this year is about 50% in efficacy, which is pretty good, or effectiveness, one of the two. Decreases your odds of getting influenza by about half. We are in a particularly nasty flu season, and hopefully everybody got their vaccine at the start of the season. One of the questions that always comes up is, does the flu vaccine last the entire season? This study looked at that issue and actually found that the effectiveness of the vaccine for preventing influenza declined slowly. For influenza B and for H3N2, the rate of fall was about 7% per month for vaccine effectiveness, and for H1N1, it was about 6 to 11% per month. But it looks overall that vaccine effectiveness hangs around for 5 to 6 months, i.e. greater than 0. We still need a better influenza vaccine, but it's still better than nothing. And another reason why you need to get the flu vaccine every year. Humans are no different than mosquitoes. When they sprayed DDT on mosquito populations, there were a few who were resistant to the DDT and survived. And this is true of infections as well. Infections never kill 100% of a population. Well, that's not entirely true, of course. I would imagine that rabies would kill everybody. But infectious diseases that is spread by human behaviors tend to not kill everybody, such as HIV. There's a group of HIV patients that are long-term controllers of the virus. And not unsurprisingly, these controllers are intrinsically resistant to HIV. And they have different polymorphisms in the HLA-B57 and the IFNL4 genotypes. That would be the interferon lambda 4, which I did not even know existed until I read this article. I will be unable to remember this when I'm done, except for the take-home, which is that not everyone is equally susceptible to infectious diseases, and HIV is no different. There are subpopulations of humans who, because of their genetic makeup, can control the virus on their own. Part of the reason why it's doubtful that any infectious disease will wipe us off the planet, that will be our own mismanagement. 2 cases of proctitis in men who have sex with men due to, of all things, Neisseria meningitidis. These were unusual strains, and they do point out that the natural habitat of N. meningitidis is the human nasopharynx. So I suppose they could have gotten it by talking out their ass. Yeah, I amuse me no end. The presumption was oral genital contact as the way this spread, but added to the list of unusual bugs in unusual places. And if you missed it, the New England Journal of Medicine this month has a review on chlamydia screening. I tend not to talk about reviews, but rather point you in the direction if you have, say, run out of Ambien and need something to help fall asleep. Don't say I'm not looking out for you. If I say cat, you should say Bartonella, or maybe the other white meat. But cats are not the only source of Bartonella. Also, it is found in bats. They are found in the bats of Spain, as this article shows, and have also been detected in the bats of Finland and the United Kingdom, where one patient had a bat-associated Bartonella endocarditis. I am sure as molecular methods become more widespread, we'll start finding all sorts of peculiar organisms causing infections in humans. Boy, this is becoming the Weird Association podcast. There was a case report of Francisella tularensis type B from Minnesota that was acquired as the result of a fishhook injury. And the same MMR report mentions a case of tularemia that was from Minnesota as well that was acquired from shaving. The two big Francisella tularensi, are subspecies tularensis, which is type A, and holarctica, which is type B. And type B is found all around the world in northern climate, like I suppose Minnesota, although water is a distinctly unusual source for tularemia. I did my training in Hennepin County in Minneapolis, my medicine residency, and am well aware of the 10,000 plus lakes, all of which I suppose are animal urinals and a source for tularemia. I don't think that's going to be the state motto anytime soon. Land of 10,000 animal urinals. Doesn't quite have the ring to it. Vaccinate the vector and other people don't get infections. You know, that whole herd immunity thing. This is well demonstrated with pneumococcus, where vaccination of children has led to a marked decrease of invasive pneumococcus in all age groups. And this is true of Haemophilus type B as well. As vaccination has gone up for Haemophilus B, you've seen declines in invasive disease in children up through age 4 years, but also in adults greater than 40 years of age. So again, vaccinating the vector prevents others from getting the disease. Part of my argument for vaccination of healthcare workers against influenza, although the data there is not as clear-cut. One inexpensive and one expensive way to diagnose endocarditis. The inexpensive way is antiphospholipid antibodies, which are markedly elevated in patients with endocarditis, and might be useful as a minor criteria. The expensive way, especially in the United States at 5, 8, or even 10 grand a pop, is a PET scan, which is now included as a major criteria in some diagnostic algorithm guidelines for prosthetic valves and pacer infections. If your echo and other studies don't confirm the diagnosis of prosthetic valve infection or pacemaker/defibrillator infection, the PET scan really is the way to go if you want to prove the diagnosis. And for a wide variety of other infections, the PET CT looks like hog heaven. Everything from valve infections to infected prostheses to which cyst in polycystic kidneys is infected. And it would probably be the first step in an FUO workup, again, if we could get it paid for. The oncologists get all the good, expensive testing. But unlike the oncologist, I'm likely to cure my patient's infection. Don't you think you should pay for it for me? Just remember the importance of doing it right from the beginning. This study looked at both mortality and recurrence in early antibiotic treatment and found that if early antibiotic treatment was appropriate, patients had both decreased mortality, a good thing, and fewer recurrences of infection, a good thing. Mortality rates were still relatively low, but It is one of the reasons I don't quibble too much about initial empiric antibiotics, because basically when you give initial antibiotics for bacteremic or septic patients, you're betting the patient's life you're going to get it right. It's hard to quibble when people basically kill everything they can think of with as many antibiotics as they can think of. The bigger question is, what do they do after 48 hours when all the cultures are back? But doing it right from the beginning is important. For historical reasons, streptomycin has been the treatment of bubonic plague. It's the first one we had available, so we've used it ever since. Are other antibiotics useful? Well, ciprofloxacin in 5 patients out of Uganda cured them all, including one with pneumonia. I would be hesitant in the United States to treat bubonic plague with oral ciprofloxacin, but it certainly worked in a resource-poor country. Cipro also works quite nicely in animal models, so it's another drug to consider if you don't have streptomycin nearby. I doubt many U.S. hospitals stock it, although you can get it in a day or two. You often don't have a day or two in someone with septicemic plague. More is not always better when it comes to antibiotics. It is certainly, though, true with daptomycin. For serious staphylococcal infections like left-sided endocarditis, daptomycin should probably be given at 10 milligrams per kilogram. This is also true for bacteremia due to VRE, and they looked at outcomes of patients who got 6, the standard dose for which daptomycin was approved, 8, which they called medium dose, or high dose, which they called greater than 10. And outcomes were better the more you got, although the difference between medium and high dose was negligible. So for all but the most trivial of infections, most patients on Dapto should probably be getting 8 mg per kilogram or more, depending on the organism and the infection. Lower doses should probably be reserved for trivial infections or relatively less severe infections like cellulitis. I've been informed I use more daptomycin than anybody else in the system, mostly because I have an older population and I can send them home on once-a-day Dapto, where they can't get sent home on once-a-day ceftaroline or the universally worthless vancomycin. A bunch of mycobacterial odds and ends. Recently, Packy, our 60-year-old elephant at the Portland Zoo, the first elephant I believe to be born in captivity, finally had to be put down because he had tuberculosis. TB in elephants is not uncommon, and there are several reports this month on tuberculosis in animals. They found, for example, TB in wild Asian elephants in India, and there are 2 case reports on that this month, and also Mycobacterium bovis in free-ranging black rhinos. M. bovis is a big problem in cows as a rule, and in England they worry that the badger is the source. In Africa you have to worry about the black rhino. So mycobacteria go from humans to domesticated animals like elephants to wild elephants, or from humans to cows to badgers, or from humans to who knows how they got into the rhino. Tuberculous Chinese poachers going after the horn? I don't know. And besides Portland, there has been tuberculosis in Tennessee zoo elephants, and now a report of TB in a pair of elephants in Albuquerque, New Mexico, that the zoo acquired from a small traveling circus. It's very hard to diagnose TB because elephants don't give you a sputum. You have to get a trunk culture. And weight-based antibiotics for a 6-ton animal would be tremendous. Plus, it's very difficult to get elephants to take their medications. They keep forgetting. Well, at least they're all going to be extinct from a combination of poaching and climate change, so we won't have to worry about that anymore. Another risk factor for human tuberculosis is cancer. And if you get hematologic head and neck or lung cancer, you have a 9-fold higher risk of developing active tuberculosis in this meta-analysis. So I don't usually think of cancer. I do think of heme cancers as a risk, but I never considered lung or head and neck cancers as a risk for reactivation or development of active pulmonary tuberculosis. And connoisseurs of Mycobacterium tuberculosis know that TB is a complex of multiple organisms, including MTB, M. bovis, M. pinnipedii, M. africanum. And also Mycobacterium tuberculosis has different clades, and a new one has been described out of the Congo. Quote, a new dominant sublineage named Congo type, found in Brazzaville. The bugs keep on changing, probably so they can kill us. But TB, like influenza, is anything but simple and straightforward. Studies have shown that infectious disease consultation for a wide variety of infections improves outcomes, decreases length of stay, decreases mortality, that sort of thing. Of course, these studies are all done by infectious disease doctors. What would you expect? This study looked at outcomes of cryptococcal disease in patients with non-HIV and compared management between ID doctors and non-ID doctors. And guess what? ID docs did a better job with a decreased chance of mortality. Although people listening to this podcast are probably aware, there's more to infectious disease than just looking up the sensitivity and giving an antibiotic. And there's now a meta-analysis of all the studies that confirms what the individual papers showed, that vancomycin plus piperacillin tazobactam increases the risk of acute kidney injury, with an odds ratio of about 3. And if you love history and infectious diseases, as I do, there's a report in the American Journal of Medicine, Scabies Outbreak in the 14th Century, Clues from the Correspondence Between Poets. A poet got some scabies, and he says in his letter, quote, I still have and do not know how long it will torment me, a dry and ugly scabies. Since 5 months, this illness oppresses me so much that the hands are prevented to use the pen and to take the food, and they serve only to scratch and scrape it. I certainly know only one thing about my illness, that it will either soon leave me or I will leave it. We cannot be together for a long time. I itch just reading that. Thank God for red. And that ends this podcast, this Puscast, a review of the infectious disease literature for the last 2 weeks of February 2017. References are available online at edgydoc.com, where you can find links to my growing multimedia empire, including my 2 books, Pest Whisperer 1 and Pest Whisperer 2. Fascinating clinical vignettes, if I do say so myself. Otherwise, as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you, in dictation, and goodbye.